corneal dystrophy test, clinical implication. First of all, let me thank SICSO and in particular Professor San Nicola, I have in front of mine here, for this very interesting, really great conference. In the meantime, I'm waiting for my slides to be screened. And so the Avellino test. Okay, so that's a test for an early diagnosis of inherited dystrophies, corneal disorders, and it's already available and it's already used in a number of patients, and more than nearly 150 patients have already been tested this way. So let's talk about the corneal dystrophy. So that's the first paper by Grenu, and then two conferences were devoted to these topics. So in red you may see the group of dystrophies which are involved in the test. The test has to do with the growth factor transformation protein, and concerns these 5 diseases you certainly are familiar with. These five dystrophies share a common mutation in a single gene and position 31 on chromosome 5. You may see on at the bottom the mutations of the gene which may then affect the phenotype of the disease. So what happens when the gene is mutated? The shape and this stereoscopic shape of the protein is modified, and this implies a lower activity of the extracellular matrix, and on the other hand there are problems of clearance, and so a build-up is formed, as you may see here in the picture. So the damage to the protein causes wrong functioning of the extracellular matrix and the build-up. And so depending on the mutation, the phenotype is different. So you may see here under the Bowman and anterior part of the stroma, and that's granular dystrophy. You may see hyaline formations and amyloid, or only hyalin or hyalin and amyloid formation. So what to do when faced with such problems? Well, there is another way. DALC certainly allows us to recover the clearness, the transparency, but we have to remember that the colonization by keratocytes certainly will bring to following opacification, and so the PTK has the purpose to smooth down the surface and reduce aberrations, but the solve isn't solved ever. So what's the problem? The problem is that the protein is over released in the presence of stimulations. So if you have an aberrated release of such a protein, will have considerable problems, and that's a paper that has been recently published. So the gene tests, or the genetic test, changes completely the diagnosis, because now we have a clear cut and certain diagnosis. On the other hand, also we can know that surgery may help. So until 2002, a case has been published where LASIK has caused a major progression of granular dystrophy type 2. Two more cases here, one after 7 years and 4 years respectively, where the transparency was lost. And so we have always to remember the roughness that is caused in the portion underneath the epithelium that is caused by these pathologies. So when I have to put a diagnosis, obviously, if I have a homozygous situation, it's easy to diagnose. But if I have a heterozygous situation, that's very tricky, and that's where I need some help. And so from top to the bottom, so here we have a typical granule dystrophy type 2, not difficult to diagnose. But as you go to the bottom, the situation becomes more and more difficult to diagnose. So what to do? So it isn't only for LASIK, but I think also of the keratoconus. We all know that these dystrophies may occur in association with the keratoconus. So we have to try and stop the development of keratoconus, but also the effects that the opacification might cause. And so these are pathologies that, unless corrected, of course, may also evolve slowly. But we have to consider possible aberration caused and what failure we might encounter. So why a DNA test? Of course, this is in order to stay on the safe side and be more certain, but also to make a differential diagnosis between dystrophies and aberrations or neoplasm, and especially to have a differential and correct diagnosis when the patient history is absolutely silent.